Hello everyone, welcome back to Dentistry Made Easy. The topic that we're going to discuss today, it is the marsupialization, which is a treatment option of dental cyst. So marsupialization, it is derived from the word marsupial, which means the mammals like kangaroo, they usually have the pouch on their abdomen where they are going to carry their baby. So basically this procedure is creating such pouch in the cyst. So first we are going to see what a cyst is. Cyst, it is a pathological cavity or sac within the hard or the soft tissues that may contain fluid, semi-fluid or semi-solid or gaseous products, and it is not always lined by the epithelium. Actually, it is a space occupying lesion with the outer wall of the definite fibrous connective tissue that surrounds a central cavity which is known as cyst lumen. So the dental cyst, it is classified into two types, that is the true cyst or pseudocyst. So true cyst, it is the one which is lined by the epithelium, and pseudocyst, they do not have the epithelial lining. Example, the aneurysmal bone cyst, and for the true cyst it will be the dentigerous cyst. So remember, initially cysts, they do not contain pus, and when they become secondarily infected, then the pus is going to develop in the cyst, and it may rise in any of the soft or the hard tissue of the orofacial region. Now starting with the main topic, that is the marsupialization, or it is also known as cystotomy. So we are going to cover in this particular video the principle of it, what are the indications and contraindications, the advantages, disadvantages, the technique, like how are you going to do it, and the modification for the main technique which is given. So marsupialization, or it is also known as PASH or decompression. So this is known as decompression. Why? Because here we are going to release the intracystic pressure, and that is the reason it is known as decompression treatment. So it refers to creating a surgical window in the wall of the cyst. So you're going to create a window in the cyst, and you're going to evacuate all the cystic content, which releases the intracystic fluid, and thereby this process is going to decrease the intracystic pressure, and it is going to promote the shrinkage of the cyst. And then what will happen is the bone from the periphery, it will fill that gap, and at the end the cystic cavity, it is replaced with the bone lining. So the only portion that is removed is the piece that is removed to produce that window. So basically marsupialization is what you're going to do is you're going to create such window such that you're going to get the access towards the cystic lumen. So by this you're going to remove the cystic content, by which the intracystic pressure, it is reduced. So it is the earliest treatment which was used, and it was first described by Parch in 1892. So here the window, it should be at least 1 centimeter in diameter, which is made into the cyst, and an attempt it is made to suture the lining to the oral mucosa, and the cyst, it is packed with the packing material. So this is basically the principle of cyst. Now moving towards the next part, that is the indications, like what are the indications of marsupialization. So first indication will be the age. Now if the patient is too young, which means the tooth germ, they are developing, and enucleation, which is the other treatment option of cyst, where you're going to completely remove the cyst, is not possible. Why? Because that will damage the tooth bird. So in that case you're going to go for marsupialization if the age is too young, or if the patients are elderly patients, debilitated patient. So in that case marsupialization, it is less stressful and it is a good alternative to enucleation. The next is proximity to the vital structures. Now when the cyst is close to the vital structures like the maxillary sinus or the nasal cavity or the maxilla, and that would create oroantral or oronasal fistula, or it can injure the neurovascular structure, or it can damage the vital teeth. So in that case you need to go for marsupialization. Why? Because enucleation basically is the complete removal of the cyst, but in this you are not going to remove the lining, only you are going to remove the cystic content. The next is the size of the cyst. Now if the cyst size is very large, so in that case if you go for enucleation, it can result in pathological fracture. So because of that you need to go for marsupialization. The other indication, if the teeth they are in erupting stage, then this procedure it will permit the eruption of the unerupted teeth. The next indication is vitality of the teeth. So when the apices of the adjacent teeth they are involved in the large cyst and enucleation it can affect it, then in such case you need to go for marsupialization. So these are the various indications for marsupialization. Now what are the contraindications? So contraindications can be fistural cysts. So in that case you cannot go for marsupialization. If the patient's compliance is poor, if it is the keratocyst, or if there are the malignant changes in the lining. So in such cases you cannot go for marsupialization. Now moving towards the advantages and disadvantages. So advantages will be, it is a simple procedure to perform. It spares the vital structures. Then it allows the eruption of the teeth. It will prevent the oronasal or the oroantral fistula. It is going to prevent the pathological fracture. It is going to reduce the operating time. It reduces the blood loss. Then it helps in the shrinkage of the cystic lining. It is going to allow for the endosteal bone formation, and the alveolar ridge it is preserved. So these are the various advantages. Now what are the disadvantages? Now in this the disadvantage is the pathological tissue it is left in situ, because here you are only going to create a window and you are not removing the complete epithelial lining. So because of which the chances of recurrence it is more. Then the histopathological examination of the entire cyst lining it is not done. The healing time it is prolonged. So this procedure it is inconvenient to patient. There is prolonged follow-up visit. Periodic irrigation is required. Regular adjustment of the plug is required. The periodic changing of the pack is like indicated in marsupialization, which is a disadvantage. The next disadvantage is there can be the need of secondary surgery. There is formation of slit-like pocket, and the risk of invagination and the new cyst formation is always there because the complete cystic lining is not removed. Now moving towards the next main part, that is the technique of marsupialization. So the first step in marsupialization is giving anesthesia. So here you can give anesthesia plus infiltration. So this can be done under local anesthesia or general anesthesia. Now the next step is aspiration. So here you can do the aspiration of the cystic content at the beginning, and then you can give the incision. So here a circular or the elliptical or oval shaped incision or a semilunar incision is made, or also a S-shaped incision can be made on the cyst, or also sometimes inverted U-shaped incision can be taken with the broad base towards the buccal sulcus. Now remember, for semilunar or the oval shaped incision, it is taken 0.5 to 1 centimeter from the gingival margin of the teeth or on the alveolar crest in the edentulous patient. Then you are going to raise a flap. So a full thickness mucoperiosteal flap it is raised, that is the subperiosteal flap, or the hydrostatic dissection can be done when the bone has resorbed and the mucoperiosteum lies in the direct contact of the cyst. So in such case the dissection of the cyst is done. So first you have taken the incision, then you are going to raise the flap. So by raising the flap, what you are going to see is you are going to see the bone which is covering that cyst. The next part is removal of the bone. So you are going to remove that bone such that now you want to make the cyst visible. So the next step is removal of the bone that is covering the cyst. Now if the cyst is large, we can see there is perforation of the cortical plate or the bone, like if it is a thin bone. When the bone is narrowed, so here the incision can be extended through the mucoperiosteum bone and the cystic lining into the cystic cavity, and you're going to send this lining for the histopathological examination. But now if the bone is intact, if the bone is thick, so what you're going to do is you're going to make the holes with the help of a burr, which are drilled in the circular shape, which are then connected, and the overlying bone, it is removed carefully with the Ronger's forceps, and now you can see the cystic lining. So first step is anesthesia. You're going to aspirate the content, you're going to give the incision, you're going to raise the flap, and then you're going to remove the bone. Now once you have removed the bone, so next is you're going to remove the cystic lining. Now this can be done by stabbing the scalpel through the lining against the bone edge. The superior aspect of the cyst wall is removed and not the complete lining is removed, as some part or the deeper part or the deeper aspect of it is left. Then we can see the content which is evacuated. Visual examination of the residual cystic lining is there. So you have removed the cystic lining. Then the debridement is done. Removal of any loose tissue is done. Irrigation of the cystic cavity, it is done with the help of saline, povidone iodine. And then the next part will be the suturing. So once you have done with the removal of the cystic lining, you are going to suture it. So suturing, it will be continuous or interrupted sutures that are given. Now that we have elevated the mucosal flap, as earlier we have seen that, now what we are going to do with that? So there are two options. First will be you can excise that flap and maintain that opening of the cystic cavity that we have made. Or the next is you can suture the flap downwards into the cystic cavity, and also you can suture it at the margin. So these are the two scenarios what you can do. So the remaining of the cyst lining, it is exposed to the mouth at its circumference. So why are you doing this? Now once the suturing is done, as this is what most commonly is done, the cavity is now packed with half or 1 inch medicated ribbon gauze, that is the Whitehead varnish. So the solution that we are using, it is the Whitehead varnish solution which is used. So this is done to prevent the food contamination, and it also covers the wound margins. Now what is the composition of the Whitehead varnish? So Whitehead varnish, it contains 10 gram benzoin, it contains 10 gram iodoform, 7.5 gram storax, and 5 grams balsam of tolu, and 100 ml of the solvent, which is the ether solvent. So with the help of this varnish, the packing is done till endoosseous healing it is seen. But remember that this procedure might fail if the opening is closed before the cavity it is completely obliterated, and that was the reason of keeping this open. So here is the main reason, as we have discussed, that we are not going to suture it completely. In fact, we are going to keep this open up such that the complete cavity it is closed or obliterated with the bone. So with the help of non-tooth forceps, ribbon gauze it is first laid along the floor of the cavity. So first you are going to place the gauze along the floor of the cavity, and then you are going to insert it in layers running from side to side. Now pack, it is usually secured with the sutures. So this pack, it is left for 10 to 14 days. After that, the junction between the lining of the cyst and the oral mucosa around the periphery of the window will be healed. Now maintaining the cystic cavity, it is very important. Hence, careful instructions are given to the patient regarding the cleaning and the irrigation of the cavity by regular flushing with the oral antiseptic rinse that you're going to give. So after 10 days in large cyst, analgesia is given for changing the first dressing, and the cavity is repacked for some days until the healing is seen. In the case of cyst, if it is large, so you're going to repack it again until the complete healing is seen. Then when the wound has healed, it is usually possible to take the impression for construction of the acrylic plug. So you're going to make the acrylic plug. Now first, make plug of resilient material to avoid the irritation, and then the acrylic plug is made. Now this is not used in every cyst. So it is indicated in the case of small bony opening with large cyst size. If the cyst size is large, so in that case you are going to give the plug if there is a small bony opening. So we make such small opening even if the size is large due to the anatomic consideration or to preserve the adjacent important structures, or it is indicated in the case of openings which is surrounded by the loose connective tissue. So in that case you are going to give the plug. Where the scar contracture, it can reduce the size. Hence such opening should be maintained by the plug, because as I said earlier, if the cavity it is closed before complete healing, then this procedure it can fail. So the reason of giving the plug, so what we have seen is you have removed the bone, you have removed the cystic lining, then you have irrigated the cavity with saline, then the suturing and packing is done. You're going to maintain it properly by giving proper instructions, then you're going to use the plug, and then the proper healing is seen. So this is the technique of marsupialization. Now then the process of regeneration it begins, and the patient is recalled at monthly intervals for reduction in depth of the plug, but maintain the depth of the opening which we have created. Now usually the bone replacement it is faster in mandible than the maxilla. So the patient, they are under observation for 18 to 20 months in the case of large cyst. Now what are the features of plug? First is it should be retentive and it should maintain the patency of the cavity, and it should not irritate the mucosa. The next feature of the plug is it should never be at the end of the depth, as it can interfere with the bone regeneration. In edentulous patient, it can be attached to the dentures also. The plug it should be vented to avoid the pressure buildup, and the plug it should be designed such that it is not swallowed or inhaled by the patient. Lastly, the healing is seen, so here the cavity may or may not obliterate totally with time. Some degree of permanent depression it remains in the alveolar process. So with this diagram we are going to quickly see about the technique. So first is giving the anesthesia to the patient, then you're going to aspirate the cystic content, then you're going to make the incisions. So here this red lines are the incisions that are made. Then what you're going to do is you're going to raise the flap. So in this diagram, as you can see, we have raised the flap. So this was closed. In this way we have raised it. Now this green portion over here is your bone. So we have removed the bone, and now you can see the cystic lining. What you're going to do is you're going to remove that cystic lining, and you're going to remove whatever the cause. So in this case the impacted tooth can be the cause. So we have removed the impacted tooth and the cystic content. So this is the way we have removed it with the tooth. The next is you have irrigated the cystic content, and then the two parts can be, you can keep it open or you can suture it. So what we have done is we have suture it downwards over here, as you can see. So you can see the suture, and the next step is giving the pack. So giving the pack of whitehead varnish, and then you're going to maintain this cystic lining properly, as we have discussed, by giving proper instructions to the patient also. And after initial healing, you're going to give the plug to the patient, and you're going to recall the patient until complete healing is seen. Now lastly, what are the modifications of this technique? So there are two modifications. First is the Waldron's procedure, which is given in 1941, or PASH 2. So marsupialization, as we have discussed, it is given by PASH, or it is known as PASH. So PASH 2 is, it is a two-stage technique in which first you're going to do the marsupialization, and when the cavity it becomes smaller in size, then you're going to go for enucleation, and later the entire lesion it is examined histopathologically. So the next modification is the marsupialization by making an opening into the maxillary sinus or the nose. Now this is done in the case of extensive cyst of maxilla that occupies the large portion of the atrium, round about half of it. So in that case you need to go for that modification of marsupialization. Now this procedure that you are making in the maxillary sinus, it is slightly different from the conventional procedure that we have seen. Now if you want me to explain that procedure also, let me know about that in the comment section below. So I'll make a separate short video on that too. So this was all about this particular treatment option of the cyst, that is marsupialization. Later on we are going to see about the enucleation also. I hope you found this video helpful, and if you did, then please like, comment, share and do subscribe to my channel. Thank you so much.